Dr. Dennis Styne is here now, who is the chair of the Pediatric Obesity Guidelines Task Force. I know this was a Herculean effort. We haven't had new guidelines since 2008. So talk about some of the key points in these new guidelines.
Well, in the ensuing 8 years, 1,776 publications have appeared on pediatric obesity, some of them quite useful. We had to review them, we had to put them in here and help the clinician and the researchers who are involved in the care of children with childhood obesity. The guidelines have touched on evaluation and treatment, and there's lots of new information which I think clinicians can use. We've looked at the statistics. We know that over the last 4 decades, pediatric obesity prevalence has about quadrupled, which is remarkable. There may be a plateau now. We might be leveling off, but that's not great that we stop at 17%.
So pediatric obesity is affecting different communities differently.
Correct. Ethnic minorities in America are affected more than Caucasians, although all groups are affected. Through the guidelines, we talked about the evaluation. We stuck with the BMI evaluation. The BMI calculation is not perfect for children, but it is widely used, and we thought it was still useful to retain it. So anyone who has a BMI over the 85th percentile for gender and age is considered overweight. When they're equal to or greater than 95th percentile, they're considered obese. Under 2 years of age, we use the 97.7th percent point for the weight for recumbent length. So we have guidelines at different ages. Problem is that clinical involvement still must be key. A child can have a normal BMI and still be, as the term we use, over fat. So indeed, clinical judgment and your visual evaluation is important in evaluating a child. We also touched on the evaluation of laboratory tests for comorbidities. Comorbidities are very prevalent in childhood obesity, and many of them persist till adulthood. We suggested which tests are useful and which weren't. For instance, we have new guidelines for the cutoff for ALT values, which are not what usually appear on the automated electronic screen when you look at the values on your electronic medical record. They're lower for children. We also emphasize the fact that an endocrine evaluation is really not necessary in most children with obesity, unless they are short or their height velocity is attenuated. That's characteristic in most cases. Not all, but most. Another point is we suggested we do not recommend the measurement of insulin. Many clinicians measure insulin thinking it will tell you whether the child will develop type 2 diabetes or other complications. In fact, it does not. The overlap is remarkable. We don't think it's necessary. We emphasize the fact that prevention is so important because treatment is so difficult, and the persistence of treatment is not long in many studies. So prevention using lifestyle modification is what we emphasize, as we always have in the last guidelines 8 years ago. We have to make sure that the child has a healthy diet, has a healthy activity level. We point out that while we would love children to have 1 hour of activity every day, we can't always get to that point. 20 minutes has been shown to be effective every day of the week, and that's one guideline which some people can achieve more easily. So we suggest that that's necessary.
Since clinicians have been giving some of these recommendations to families over the last 8 years, and yet the childhood obesity rates are still rising, maybe plateaued now, but during that time we're rising, is there anything in the guidelines to help them communicate better with parents about the dangers for their children?
The method of approaching a parent is very crucial. You can get people very upset very quickly when you tell them their child is obese. We don't use that term. We talk about lifestyle changes. Communication is difficult because many parents don't recognize that their children are indeed obese. Sometimes the parents also are obese and don't recognize that either. So we have to be very careful with what we say. It's important to realize that the clinician cannot solve this problem. This is a societal problem which involves the environment in which the child is raised, which means the houses they live in, the neighborhoods they live in, whether there's play structures or playgrounds available to the children. So many features that are beyond the realm of the clinical office. We must advocate for children, as we do as pediatricians, characteristically, to make sure that the child is raised in a healthy environment. And that's not often the case, unfortunately.
Well, when you talk about this, you talk about it really being part of society, and I know there's also a section looking forward on the unmet needs, even in research, for figuring out what is important.
We pointed out unmet needs in this field, certainly. the necessity for further research to look at long-term studies to see what is the best way to prevent childhood obesity. Clearly, healthy lifestyles are important, but other factors are important as well. And most importantly, long-term studies on the treatment of childhood obesity, so we have a lasting effect. In addition, how do we change the environment that the child lives in to make sure that they are healthy in the food choices that they take, the activities that they engage in, and their psychological well-being as well. The guidelines point out the fact that so many children with obesity have difficult psychological situations and how we should screen for them. The guidelines also talk about the evaluation for genetic causes of obesity. Now 7% of the most seriously obese children may have genetic etiologies, and we suggest a way to evaluate that.
All critical information for children's health now and in the future. Dr. Styne, thank you so much.
Thank you.